Staten Island.
Listen to the talks, but if you have any questions for any of the panelists or for myself or anyone in the room, tweet to us your question. And at the end of the panel discussion, we're going to have your questions and we're going to talk about them, okay? We're all going to answer them. So it's going to be somewhat interactive. It's the only way to get all of you in this huge hall to kind of ask your questions, okay? All right. So first, we're going to talk to Dr. Abbas Hussain, and we're going to listen to one of his terrifying pediatric horror stories.
This is a big space. I'm going to tell you a story about a 12-year-old boy. Let's call him Mohammed. It's not his real name, but it works. So I met him as I came on to my night shift. Hold on. Okay. So as the night shift dog, I walk in and he's sitting there. The day team had evaluated him and had a concern for appendicitis. He had a tender abdomen. So they ordered a CT with oral and IV contrast. I know you guys are shuddering over here, but keep in mind this is 10 years ago. And this is before we were fast out with bedside ultrasound, or the surgeons were. So he's there sipping on his gastrograph and having a good time. And I speak to them, and he seems to be otherwise well, other than some tenderness in his abdomen. So I let him continue sipping, walk over, see the Rugrats and ankle biters that are waiting for me. And a little while later, he goes to CAT scan. And then you hear the thing you never want to hear, especially during a night shift in pediatrics, is rapid response, CAT scan 1. So we rush over, and sure enough, he's sitting there at the edge of the bed, flushed. The tech said he almost passed out. So what do we do here? Right, so first mistake, I just coaxed him down, let him to look flat, assured the tech, and kind of did the scan. Now, just keep in mind that I never reassessed him. I never got a blood pressure, never got a heart rate. He was not on a monitor. And you may think it's a 12-year-old kid getting a CAT scan of his belly. You don't need to do that. But if somebody's situation changes, you have to fall back on your safety net. And we kind of let him go and do the scan. He came back. As I'm back here, now he's being rushed back by the nurse. He finished the scan, but he looks gray, ashen, pale. And he gives me that I'm about to die look, and I was like, oh my God. And for all you guys here, we've all been there. I had no idea what was going on. And I'm sure when you guys, as interns, as second years, approach a patient, you're like, oh my God, I have no idea. We've all been there, every single one of us. I bring him back and do the things that I know how to do, put him on a monitor, put an IV, get a second IV, give him a fluid bolus. And yes, for all you people, he has normal saline, not lactate, don't kill him. Then I get a panic call from a radiology resident. It's the largest pericardial effusion that they've ever seen, and there's signs and symptoms of tamponade. And I'm like, oh my God, I have no idea. I've never done this. I've had this kid with this. How do I do? what I do next. So I call my consultants. I call the pediatric cardiologist, the cardiothoracic surgeon, and they're rushing in to take care of the patient. Meanwhile, I get a bedside echo, and sure enough, definitely agrees with what the scan shows. And then his pressure starts to go down. Is it 60 over 40, 40 over nothing, and then he starts rolling his eyes back. Thank goodness the CT surgeon had rushed in the room at the same time. We were able to, so we grabbed all the setup that we had, took the 18-gauge spinal needle, put it in the subxiphoid space, everything we always train about, and the blood just rushes back. It pushes the plunger back, we pull back 20 cc's, another 20 cc's, another 20 cc's. And at that point, I'm like, oh my God, did I just harpoon this guy's left ventricle? Like, what the hell's going on? But then I look up, and the kid starts to pink up, he starts to get better. So we put in a catheter, we hook it up to a pleurovac, and we get 2.5 liters of blood fluid out of this kid's heart. And he felt great. Now, think about it. It's a slow accumulating effusion, right? We've all been taught it's a large effusion, accumulates slowly, so kids can compensate so well. This kid is probably like, well, this is my life now for the past 2 weeks, and this fluid's slowly building around his heart, and he's just thinking that this is what life is like. And he's getting through his day. Now we finally took that out, and he was like Superman. He was like, this is amazing. To cut it short here, so the kid goes up, gets a window, gets discharged a few days later with a pretty negative workup, and they found he had a side of viral myocarditis causing a pericardial effusion. Months later, he's playing baseball and he's doing great. So that's my story.
So that is insane. The guy came in, he's 12 years old, he's got abdominal pain. It's obviously appendicitis, and clearly the initial providers were probably great people who thought it was appendicitis, and lo and behold, the kid crashed. So, I wanted to ask you, did you learn anything from this that will help you pick up myocarditis, or is this just the needle in the haystack, and this guy came in and there's no way anyone would have found this?
I think in this day and age it would have been very different, especially with bedside ultrasound. It may even have been worse, because we would have examined his abdomen, did ultrasound in his right lower quadrant, and possibly even reevaluated and discharged him, because he looked that great when we initially saw him. It would have done nothing more. Thank goodness we did a CT on him. Of course, if monitored closely, any intern who had put a probe on his heart and been able to tell that, but identifying it, thinking about it, is the hardest part.
Was he tachycardic at all?
I think he was slightly tachycardic.
Did you want to say something about the tachycardia?
I mean, just that's, I don't know, always other things you look with. I hope, like, it'd be really terrifying if he was a tachycardic, because, like, I feel like that's my, like, safety net, is that I'm not going to send home if they're tachy. But, like, if you, like, normal pulse rate, that would just be, like, absolutely terrifying. You could totally discharge the kid.
Yeah, I think the only distractor, I think he was a low-grade temp, like 100.9, and, maybe low hundreds tachycardia, which just blown off on that.
So I think the important take-home points from that story is, one, kids look good until they crash. And I know we keep saying it, but anyone who's been doing this long enough who's seen a sick kid will say the same thing. And then the other thing is, when they look sick, they look really sick. So if a kid is not responding as they're supposed to and something doesn't fit, take that seriously. And I think you brought up a good point. Nowadays that we have ultrasound, we should be doing ultrasounds on kids more. I don't know why we don't do them as often, and especially with a sick kid. So that's a really great story. Thanks for the learning points. All right.
Hi. Okay, my horror story did not start on a dark and stormy night. Instead, it started on a fairly mild shift, not a terribly stressful one. It's a peculiar one we have at our institution, where the doctor's kind of a greeter doctor, kind of go around and see people as they're coming in and been waiting a little while, trying to make sure they don't wait too long, and get things started, say hello, let them know we care, and get their workup going, and then move on, which I kind of like. And also I respond to trauma codes. So anytime there's a call overhead, trauma notification, I'm gonna run to that, switch gears, be all on. In this particular time, though, I didn't hear any call overhead, but my wonderful colleague, Jeff, comes and finds me in the back of the ER, and very straight-faced, I don't know, some of you know him, but he's not always the easiest person to read. I read nothing except, we're gonna go take a look at somebody. And he's covering peds, so I think we're gonna go into the pediatric area. But instead, I see we're walking to the recess room. So I'm starting to change my mental state. Oh, we're going to the recess room. This is a sick kid we're going to see. And I walk in the door, doors open up, and it's Max. I see a 13-year-old kid looking in a great deal of distress, seeming to have difficulty breathing, and my brain in the background is screaming, holy shit, that's Max. And I'm telling myself, right, this is when you do that tactical breathing thing. I'm taking slow, deep breaths, holding my breath, letting it out. As I'm hearing the story, this is a 13-year-old boy who was hit in the neck with a football, and after about 10 minutes, is developing respiratory distress and severe pain. He's already on the monitor, he's tachycardic, and I see him, he's panicking. And I know this kid. Like I said, this is Max. This is my best friend's 13-year-old son. Same class as my own son. So, my heart rate is almost as fast as his, but it's slowing down a little bit because I'm doing my breathing. And I'm thinking, as Dr. Levitan said, I have to compartmentalize this. That piece has to go in another box for right now. Right now, I'm dealing with this kid. So, but I do know him, and that is a help. So I look at him and I say, Max, it's Laura. Look at me. Look at me and tell me what's going on. What's happening? Are you okay? And he says, I can't breathe. I can't breathe. It really, really hurts. But he said it with words that I could hear. So that really made me step back a little bit, because I'm thinking as I'm talking to him and I'm hearing the story, I'm thinking in my head, okay, I'm gonna have to intubate Max. I'm gonna have to intubate him, take his airway because he has some kind of laryngeal fracture or something. As he's talking to me though, I hear his words. I'm looking at his neck. There's no bruising, there's no swelling. I touch him. Max, you're gonna be okay, you're gonna be okay. But then I also put my hand on his neck. I don't feel any crepitus, I don't feel any swelling. But he keeps doing this kind of intermittent, looking like he can't get air in, kind of stridor, and then again, kind of crying and saying he can't breathe. I grab the ultrasound. This is telling me I have a little bit of time though, and it's saturating well, still tachycardic. Telling me I have some time. So I grab the ultrasound machine, which is right next to the bed, and I ultrasound his neck. There's no sign of air. There's no edema. I actually, for an old lady, I can find the cords, and I see the cords moving while he's breathing. So that tells me again, okay, I'm going to trust my instinct here. My instinct is telling me that this kid is not actually about to lose his airway. I think this is anxiety. And in my head comes episode 179 from MRAP, you guys can look it up, in which Rob Orman and Anand Swaminathan discuss a case where Dr. Orman gets a notification that he's getting a kid who's been hit in the neck with a lacrosse stick and is in respiratory distress. It's his chairman's son, a similar kind of high-stress situation. And it turns out the kid is having an anxiety attack. Similar thing in that once he realizes the kid is speaking to him, he knows he has time to wait. So as Dr. Orman did, I give pain meds. I do Decadron and racemic epi, thinking, can't hurt. I give him some Ativan. And it's getting better, but it's not perfect yet. He's still doing this, but it's better. So I'm going in the right direction, not the wrong direction. Then my friend comes in. So the mom arrives, but the mom is not just the mom, this is one of my best friends, who is both really relieved to see me, and also we're both aware that this is just not the way life is supposed to go, right? So I have her and her husband talk to Max, and it seems, that they're able to talk, but again, it's not perfect, it's not going away. So I have to take my friend out of the room, and say, hey, you know, this can go a couple of different ways. One way is we keep watching him and he gets better and better, and this has a happy ending and we go home. And the other way is I have to intubate him, which means I have to put a plastic tube in his throat, down into his trachea, and breathe for him. And that's a hell of a conversation to have with a really good friend. I mean, it's a hell of a conversation to have with any parent, but it does add that little extra bit when it's someone that you know and love. So, and then I also ask her, as I would with any parent, what do you think? Not what do you think I should do, but what do you think is going on with your child? Is your sense that he's really in trouble, or is your sense that he's more frightened and in pain than he is really sick? And she basically said, no, I think what you think. I also think that he's more anxious, and I wanna wait. Let's wait. So one of the good things about this shift is that I have, because I don't have lots of other patients, I'm free to basically stay there. So I stayed at the bedside with them over the next couple of hours, and he gradually got better and better, and it did have the happy ending, and he was able to go home. That's my story.
Really big relief. I'm glad it did not go the other way because, your life would be different. Do you think, now question, because I actually have not yet had a situation where a really close friend or family I have to take care of, thank God, I don't want to be in that situation. Did you change your medical practice because it was your friend's son? Did you feel like you made different decisions compared to a normal patient?
I feel like I was very much aware that physicians often, we downplay our friends and family. We often think, I know my own kid had scarlet fever for 5 days before I decided it wasn't just a virus. So I was aware of that. I was also aware that, I didn't want to intubate Max. I didn't want to have to tube him, but and also at the same time, how would I live past him dying, right? How would we all have lived past that? So those things were in my head, but like I said, I've quoted Lemony Snicket before in this very venue, where I've said, basically, I'm going to be afraid of that later. It's really scary, but I'm going to be afraid later, and that's basically what I tried to do.
Yeah, that's that compartmentalizing. You recognize it, you put it aside, and you can deal with it later. And it's good that you kind of practice normal medicine because research studies have shown that VIP care is worse care. Treat every patient like you would any patient